Deep listening.
الاستماع العميق.
Deep listening.
Intensiv zuhören.
Deep listening.
Deep listening.
深度聆听.
Deep listening. Impact beyond words.
She opened the door, was standing outside the room, but she didn't let go of the doorknob yet. She said, "Excuse me, doctor, can I ask you one more question?" I said, "Sure." And she said, "Do you think that the fact that it matters that all these aches and pains are spots where my boyfriend shot me with a dart gun?"
Hi, I'm Oscar Trimboli, and this is the Deep Listening podcast series designed to move you from an unconscious listener to a deep and productive listener. Did you know you spend 55% of your day listening, yet only 2% of us have had any listening training whatsoever? Frustration, misunderstanding, wasted time and opportunity, along with creating poor relationships, are just some of the costs of not listening. Each episode of the series is designed to provide you with practical, actionable, and impactful tips to move you through the 5 levels of listening. So I invite you to visit oscartrimboli.com/Facebook to learn about the 5 levels of listening and how others are making an impact beyond words. In this episode of Deep Listening, Impact Beyond Words, we hear from Dr. Danielle Ofri on the cost of not listening in medicine. There are so many parallels with Dr. Michael Boyce from episode 22 and the impact that the medical system has on patients when doctors aren't present, engaged and alert, when they're not listening carefully. Danielle explains how the average doctor interrupts the patient less than 20 seconds into the consultation. This reminded me of the amazing interview in episode 28 where we spoke to Vanessa in Japan who visited her doctor and was completely swamped and overwhelmed when she was told by her doctor that she had breast cancer, a diagnosis she was completely not expecting.
I remember when I was first told, or when I was walked into the office ready to get my test results, and I did have my husband with me, and I was expecting it to be good news. Oh, it's just this kind of benign lump. The biopsies come back and it's all kind of, I'd convinced myself that it was going to be fine. So I hadn't actually prepared myself for anything other than, it's a benign lump. And bless her soul, my doctor, the first, not the actual surgeon, she just said, "So you've got cancer." That was the first words out of her mouth. And I just went blank.
Danielle talks about this during the episode, so listen out for that. Danielle has written a wonderful book called What Patients Say and What Doctors Hear. This isn't based only on her personal experience, but she's undertaken extensive research across North America and many other locations to dig into the disease that creates the largest number of medical errors and malpractice suits: not listening to their patients. This week I was touched. I received an email from Patricia in the Netherlands who explained how she's been using the 5 levels of deep listening in training with healthcare professionals to work with people with autism. I haven't met Patricia, but I'm honoured that the 5 levels of listening are being used all around the world, whether it's the Netherlands, Germany, United Kingdom, Canada, the USA or New Zealand. There are many organisations integrating deep listening impact beyond words into what they do. To Patricia and the team of medical professionals in the Netherlands, thanks for having an impact beyond words. Now, let's listen to Danielle.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening.
It's interesting because in the book that I've just written about communication, the book What Patients Say, What Doctors Hear, I spent a lot of time, as you mentioned, looking at the downsides to miscommunication in terms of medical error, misdiagnosis, medical adherence, just actual dollar costs in the hospital. But the book I'm working on now on medical error, in some ways, feels like I'm almost writing the same book again, because so many medical errors boil down to communication. And in fact, it's probably the majority of medical errors that come to that. If you dissect down malpractice data from the US, more than half of the malpractice lawsuits come down to communication error of either speaking or listening or transmitting information. And only a small minority are the actual true malpractice, cut off the wrong leg, operate on the wrong side kind of error. So just in that realm of medical error and cost, miscommunication is enormous. But there's also a whole other side of communication in terms of the investment in the doctor-patient relationship. And as an internist, I was in clinic this morning, and one of my patients is someone I've been seeing for, probably 8 or 9 years, an older woman in a wheelchair who has cerebral palsy. And we just uncovered this month breast cancer. And it's very tragic. And I, of course, feel terrible. This sort of crept up on us. We didn't catch it and suddenly just appeared. But I also feel so relieved that we have this whole history of 8 or 9 years together, that now that we face this new challenge, it's so much easier because we already know each other well from so many visits of just chatting, catching up on life and things like that may feel like small talk, but in fact lay down the groundwork. So when the real big, heavy things come up, you already have the scaffolding.
Are there some things that you do yourself when you're seeing a patient for the first time on a really busy scheduled day that keeps you in the moment?
Well, it's always busy, but I do try to take a few minutes to prepare before the patient comes in. So I'm not glancing at the chart when they walk in the door. Just today, the nurse said, "Can I bring Mrs. Jones in?" And I said, "Oh, no, not yet. I haven't looked at her chart yet," because even though I could do it while she's there, I feel less present. So I'd rather have the patient wait a few more minutes outside and I do all the background work. And then when they come in, I can then look at them and talk. And what I try to do is to see if I can spend even just the first minute or two fully engaged in the conversation without taking notes, writing, looking at the computer. And then once I've gained that sort of basic groundwork, then I may open up the chart and do some background work and do some writing. Otherwise, it's so easy to get lost in the details of the computer. And then the other thing I try to keep in mind is that although for me, this patient may be one of 10 patients I'm seeing this morning or 20 patients on the hospital ward, for that patient, they may have waited months for this visit or weeks, or been waiting all day in the hospital for the doctor to come. For the patient, this is the one moment out of many others that's so important. And try to keep that in mind. And I remember when I've accompanied a parent or a grandparent to the doctor, how important it was for them and how meaningful it was. And so try to just keep in mind, for the patient, it's a singular moment. Even if for the doctor or nurse, it's one of many in the day.
This wasn't always the case for you, and maybe there was a tipping point where you were looking at charts as people were coming into the room and not maintaining eye contact. Was there a time or a patient you saw that was a point at which you said you had to change?
I don't think there was a particular patient, but I think I would say going through illness with my own father and my husband's parents gave me a little more of the view on the patient side of how important that visit is and how meaningful it is. And it was, my father passed away a few months ago. So we've had the last year or so of being just very involved on the medical side. And even, in his last few days in the hospital, waiting around for the doctor, when the doctor finally showed up, it was so important. Even if the doctor, when the doctor was rushed, I was so angry. This is our moment. We've waited all day for you to come by. And I think it's spending a little more time on the patient side of things that really made me understand how important even a few minutes of presence really means. What I really noticed was the differing priorities. And with my father, we were getting ready to bring him home. And we were all set up, got him dressed and got the ambulance to come and the wheelchair. And the nurse came by and said, "Oh, his magnesium is low. He's got to stay another day and get another IV, replacement." Of course, and his IV was taken out. And I said, "This is crazy. I know as a physician that magnesium is not an emergency. He can go home." "No, this is what the doctor said. The surgeons are now in the OR and they can't be reached. It has to be done." I was so angry that we had to get him undressed, put another IV in and cause pain. The next morning, I got there at 6:00 in the morning and barricaded myself in the room and would not let them draw any more blood. I said, I don't care what the results are. He's got to go home. And the doctor kind of gave me a fight. I said, okay, fine. If you refuse, well, but I realized that you need an advocate. And that if I hadn't been there, my father would have stayed even longer. And each time someone stays long, an elderly person, another thing goes wrong. He never would have gotten home. And we got him home that day, and he was able to spend his last few weeks at home in his own apartment, in his own bedroom, with the window open. And I was so grateful that we could have achieved that. But it was really quite a fight. And I had to buck the medical establishment. And I could do so because as a physician, I knew what was going on. And I recognized that if I didn't know that, it would have been so hard. And that so many patients, most people don't have a doctor on hand in their family to do this sort of fighting, or to get there at 6:00 in the morning. And it's, in some ways, the system is so stacked against the patient. The patient gets lost in the mess of all these different power struggles and these different hierarchies. And it can be so hard to fight your way out. And it just gave me a sliver of insight to what hard work it is to be sick. Forget the part of actually being sick. That's the logistics of being ill and navigating that. It seems so unfair that we burden patients who are already ill with everything else you have to, figure out. And it just doesn't seem right. So that was my big learning experience.
How would you quantify the cost of not listening inside hospitals today?
I think it's an enormous cost. I'll relate to you a clinical study from back in the 1960s, which my kids call the olden days. But it was a study that was looking at post-op pain for patients who've had abdominal surgery. And if you've ever had abdominal surgery or know someone who has had it, you'll know how painful it is when the anesthesia wears off. And the pain is so powerful, it usually requires very strong pain medications, such as opiates, narcotic medications. And these medications, of course, have a myriad of terrible side effects that range from nausea, vomiting, stomach upset, constipation, to addiction, respiratory suppression, and death. So minimizing narcotic use is an important priority for everyone involved. And this simple study took 200 patients who were getting abdominal surgery. And the night before, the anesthetist went bed to bed to discuss the surgery coming up as per usual. But for half the patients, randomly selected, they added in a 20-minute discussion about post-op pain. And there was no rocket science here, just, about where the pain usually occurs, when it might come, how it's caused by the clenching of the abdominal muscles. And here's some exercises to relax your muscles. And if that doesn't work, here's the button to call the nurse. And if the nurse comes, here's what you might get. Again, nothing brilliant. And the next day, the surgeons, who didn't know which patient was in which group, operated and took care of the patients. Now, I think from the perspective of today, it seems obvious that patients with the extra discussion probably had less pain. But it was the magnitude of that difference that really made me pay attention. Those patients who had the extra 20-minute discussion needed half the amount of narcotics, right? 50% less of these powerful pain medications. And frankly, as an internist, anything that reduces constipation gets a gold medal in my book. But beyond that, those patients were discharged from the hospital 3 days earlier. That's 3 fewer days of hospital-acquired infections, falls, blood clots, urinary catheter problems, not to mention some $15,000 or $20,000 in today's dollars. And that's amazing, all from a 20-minute discussion on the very basics of pain. So if you just extrapolate that, and that's one tiny aspect of medicine, but just imagine that on many more aspects of how to take your medications. When's your follow-up appointment? Simple things like that get lost in the shuffle. I mean, when a patient is discharged from the hospital, so much is going on. They're given a list of medications, a list of appointments and physical therapy and a CAT scan to go for and all these things to do, that if even 10% gets lost in the shuffle, that could add up to a readmission to the hospital because they forgot 1 or 2 key things in the big swell of things happening.
Well, nearly $15,000 to $20,000 per day. And if they're getting discharged earlier, the savings must be enormous. and the reduction in infection that you mentioned, quite staggering to me as someone who doesn't participate in those systems. One of the stories it reminded me of when we interviewed Vanessa Oshima out of Japan, and she was a market researcher for Coca-Cola at the time. She was diagnosed with breast cancer. And one of the things she mentioned is the minute the word cancer was mentioned by the doctor, she shut down. Her listening stopped, and she couldn't hear any other words the doctor said from that point on. And she said, although I'm sure it was really important, the minute the word cancer was mentioned, she moved to another place. Danielle, is there anything you do to help the patient listen to you? Anything you do deliberately to ensure the patients heard what you've said?
Well, I typically start by asking a patient what they understand thus far about their condition. And particularly when you're about to unload something like a cancer, something heavy like that, it is very important to see what the patient is thinking. Because if they're thinking they're having a stroke and you're about to tell them about cancer, it's very important to know that, first of all, to be sure that they're not having a stroke, but to help clear up misconceptions. I also ask patients, how much detail do you want to know? And not everyone wants every nitty-gritty. And I think sometimes in the name of patient autonomy, we unload every last detail on the patient and say, okay, now you decide, right? Patient autonomy. And that's, of course, not autonomy. That for some patients can be overwhelming. And there are some patients who will say, I don't want all the details. Just give me the basics and tell my adult child or tell my parent, or my sibling the details. And I can respect that. I want to give them the opportunity before I unload that. On some patients say, I want to know everything. So having a sense of where they're coming from with their knowledge base, how much they want to know. So that's usually my starting point. And then I will be honest about the information. And then I'll make sure that before I've told them the diagnosis, that I've done my homework and I have the plan ready. So, for example, the patient I mentioned who I saw today who had a new cancer diagnosis, I got the lab report. I knew it was cancer, but I didn't call her. I waited a day or two because I wanted to get the entire treatment plan lined up. So when she said, well, what do we do now? I then said, okay, here's the plan. Because if I called her and then had no answers for her questions, I think it would leave things more, more confusing and more disturbing. Then she'd have to live with this information and no roadmap. So I try to take the time, if it's possible, to get my ducks in place. Okay, what are the statistics? What is the plan? What's the treatment? What are the side effects? So when they have questions, I can answer them. And then I make sure we go back at the end because I realize, like as you mentioned with this other person you interviewed, that once the word cancer or stroke or big things come out, people miss a lot. So I go back at the end, review the things, I write down the key points. I'll also say, is there someone else you'd like me to talk to? Maybe they didn't have a chance to bring in a spouse or a friend. If they give me permission, I'll then call this family member or friend and give them the key points that can help reinforce that. And then I follow up with another phone call. I check in a few days later. How are you doing? I know we talked about a lot. Do you have any more questions that anything didn't make sense? Because things often come up later and you need a second chance to revisit these very heavy diagnoses.
My communication has been impacted in significant ways since reading this book. I've had my awareness raised. I've always seen myself as a strong communicator, but I can already feel the difference. I listen more carefully, I feel more attuned, and my relationships are richer for it. This is a book that you can read in about an hour, but the value is not in reading it. The value is in studying it, pondering it, and practicing it. And if you do, the results will be instantaneous.
What an extraordinary example of empathy and true patient-centric medicine. I sense a lot of doctors would want to basically get through the appointment and move on to the next one, but the care you took to wait a day because that was the right thing for the patient, not necessarily for you, probably something that isn't taught in medical school. Can you think back to the time you were studying, and what's your one wish that you would have been taught about listening during your time studying as a doctor?
I think when I look back to my best lessons, although there were fewer than the others, were the times we sat with an experienced clinician and watched them just talk with the patient. Those, I can remember my first or second patient interviews with such clarity. I've forgotten everything else from my first year in medical school, but sitting with a doctor who took the time, I even remember as a first year medical student on the psychiatric ward, interviewing as a group with a patient. And then the doctor called us out after we met up and she said, I think he saw you as very naive and kind of told you what you wanted to hear. Let's go back and talk to him again and see if we can push a bit below the surface. And with her encouragement, and she prompted the conversation a bit, she got us to get below, whereas I would have walked away from the first conversation thinking that was it, I've gotten the story. But she was able to pick up that it wasn't a very authentic conversation. And the patient was withholding for whatever reasons and took the time to go back and dig deeper. And there was much more below that. I've forgotten just about everything else from my first year in medical school, but I've never forgotten that approach and what she got out of taking the time. She listened deeply enough to catch that we weren't completely done yet.
So she noticed something you didn't, and she was listening differently. What do you think she heard that you weren't hearing at that time?
I think what she heard as an experienced psychiatrist was that he was too smooth. For the sense of what she knew of his condition, his responses were very pat and very easy, and they were the perfect responses. And because he seemed to know what we wanted to hear, and he filled that right in. And of course, we were anxious to hear that, so we checked our boxes off in our head. But she saw the mismatch in that it was too perfect for his known diagnoses. And so she suspected that there was more to be seen underneath. And so from that, I took the idea of, the first conversation is just the entree. And not always, but very often, we can circle back and there's more. And so maybe I'll say at the end, is there anything else you think you want to add? Or here's what I've gotten so far. What am I missing? And then sometimes if I have a student with me, I might say, you know what? We've got a student today, you as an experienced patient, what's a lesson you could give to them to how to be a better doctor? And patients always have things to say to that. And it's always very telling because it'll be based on their experiences. So they may talk about getting a diagnosis poorly given or not getting the medications correctly. And then I'll know, that's probably an important point for this patient because they've brought that up now.
A really powerful example of level 4 listening, to explore what's unsaid in your questions there. In your own work and your own practice, is there a story that comes to mind where you explored, is there anything else and you were surprised and the patient diagnosis took a different turn?
Yeah, there was a patient, it really was her initiative more than mine, but a young woman, I remember she was wearing a baseball cap and she came in just complaining about a fungal rash on her scalp. Very simple and easy to treat. And then she mentioned various aches and pains in different parts of her body and things that didn't add up to any particular syndrome. It was an elbow, it was a knee, it was the side of her thigh. And I examined her. She was perfectly healthy. And I said, just sort of the aches and pains of life. And, I'll see you next year kind of thing. And then we said goodbye. She walked out. I went back to the computer to start writing. And then she was out in the hallway. She opened the door, was standing outside the room, but she didn't let go of the doorknob yet. And she said, "Excuse me, doctor, can I ask you one more question?" I said, "Sure." And she said, "Do you think that the fact that it matters that all these aches and pains are spots where my boyfriend shot me with a dart gun?" And I realized that, of course, there was domestic violence underneath all this, and I had missed it, and I really should have. When someone has disparate aches and pains that don't add up, you really do want to query about intimate partner violence. But I hadn't. I was really staying with the surface. But she, luckily, held on to the doorknob, and I feel was courageous enough to stay holding on and to push one more time to get me to hear. And luckily, I caught it because we know that these are people who become murder statistics so easily in these situations. And I was so grateful that she did this and reminded me that I've got to always be careful to make sure nothing else is going on underneath.
At that door, there were two paths that were possible. One is kind of very difficult to even imagine. Thanks for taking that extra time with that patient. I'm sure it made a lifetime of difference to her.
The other thing that I find, because the medical interview these days is often conducted with a computer between the doctor and patient, which really inhibits, I think, good conversation and good listening, is that the physical exam is now the safety valve for listening and conversing. And that once we move to the exam table, now we're communicating without the computer between us. And we're also touching, and touching adds a kind of intimacy. It's non-romantic, but it's an intimacy nevertheless. And any intimacy changes the dynamics of conversation. And countless times, that's when a patient will say what's on their mind. I look at it as my second chance at good conversation.
Compared to when you started off in practice, have you moved when you do the physical examination, knowing that there is this new technology in between the patient and yourself?
Well, I do try to get to it sooner. I mean, I usually have our conversation first and then do the physical exam, but often I leave the physical exam to the very end because it's less important diagnostically. But now I try to do it sooner because it's part of I see it as part of the history taking. And we sort of continuing the conversation, as we're touching and as we're away from technology. I mean, there's so few moments in life of communication without technology interfering. It's quite rare. And I think in that manner, very unique and special. And we should really take advantage of these moments to communicate with nothing in the way at all. And it really does create a different sort of connection.
Thinking about what this conversation will be prompting for those listening, and when I think about them, they're all telling me they're really, really busy, and having the luxury to listen for a long period of time is just not something that they've got time to do. What advice would you have for them?
I sympathize because we're all in the same boat. But, the research shows that doctors cut patients off within 8 to 10 seconds, some very short amount of time. And, there's all kinds of problems with that and medical errors. So I wondered how long patients would talk if we didn't, interrupt and cut them off. And in fact, the data show that patients usually only talk for about 90 seconds before they come to a natural halt. Well, 90 seconds, I can do that as a listener. I can let them talk. And when I've tried that, it is true. Most patients will stop within a minute or so. So if you give someone even just 1 minute of what I like to call full frontal listening, no interruptions, no computers, maybe just taking a note or two and just nodding, the patient or whoever you're talking to, A, will give you the most important information, and B, will feel listened to. And that alone is worth so much. And in my patients, the ones who tend to be the chronic, quote, complainers, if I let them talk, they too come to a natural end, maybe a little more than 90 seconds, but they also within a few minutes will come to an end. And once I let them do that, they're much less anxious. And they don't come in later, I've got 16 more things to tell you. And lowering their anxiety level and engaging their trust with those 1 or 2 minutes of full frontal listening is incredibly valuable. And it's an investment in your future relationship. And so I advise people in any walk of life, just try that. Just give 1 minute of listening. And you'll see that you don't need to take an hour. I mean, an hour is great if you got it, but often we don't. Try that minute. And what I do in my circumstance with a patient, we'll do a minute of listening. And then I'll say something like, I don't want to miss what you're saying. Would you mind if I took notes while you speak? And then I'll get to the computer. And that way I've pulled it in, but I've also still given them that full focused listening.
Deep listening.
הקשבה עמוקה.
L'écoute profonde.
Deep listening.
First off, a big thank you to the 1,464 people who undertook the Deep Listening Survey. The questions were designed to understand what frustrates you about what other people do when they're not listening. Understand a little bit more what you struggle with when it comes to listening, and ultimately, what's the one thing you want to do to improve your listening? Watch this space. We're going to use that information to help build out and provide more information that's more practical so that you can apply it to become a deep listener. Listening to Danielle as an intern and how her supervising doctor taught her that patients sometimes are going to provide perfect answers, and if you're not listening deeply enough, you may miss it. How many people are you listening to right now who are providing the perfect response to your questions, eagerly allowing you to tick the listening box rather than being curious and listening a little bit more? I'm completely fascinated by many of the insights Danielle provided, especially when it came to helping out her patients. Here's some questions I loved, and Danielle posed all these while exploring level 4 in how to listen. She was listening for what was unsaid. Take a note of these questions and see if you can use them yourself. What do you understand now about your condition? How much detail do you want to know? Is there someone else you'd like me to talk to? Is there anything you would like to add? Here's what I've heard so far. What have I missed? Is there anything else you would like to ask me? What I love about all these questions is practically they can be applied to any conversation. I love this term that she used, full frontal listening. Intention was dripping from every syllable when she said, just take the time to provide 1 minute of full frontal listening, not an hour, and you'll transform your own understanding as well as theirs. So thinking about what I'm going to apply from this interview, well, I make a lot of default assumptions in everyday conversations. So I'm going to pause a little bit longer and think about listening to what they haven't said, thinking beyond their perfect response, and trying to understand a little bit more in terms of full frontal listening. I wonder what you'll apply from Danielle and today. Thanks for listening.
Deep listening.
Deep listening. Lourdes Lascelles.
Deep listening.
Deep listening.
Whakarongo Pohonu.
Deep listening. Impact beyond words.